I would say the number of organisms is not more than 10 to the power 5. So there's a chance of contamination. The thing is we need to have 10 to the power 5 of a single organism to call it a urinary tract infection. Because of that organism, it could be E. coli, it could be Pseudomonas, it could be Klebsiella. We're going to discuss in detail later. Urinary tract infections are a common and important clinical problem in childhood. Although we feel as in adults, it's a very less common, diagnosis. But in children, especially under 5 years of age, and especially in females, it is very common. Upper urinary tract infection. There are basically, if you divide it on the anatomical background, so we can say when only the urethral area or the bladder is infected, we call it lower urinary tract infection. And whenever there is involvement of the upper kidneys and ureters above the bladder, it would be called as upper urinary tract infection, and we call it acute pyelonephritis. And it is something which is serious, because if a child or even an adult continuously gets infected because of upper urinary tract infections, it can lead to renal scarring, which can ultimately lead to the shrink or the small size of the kidney, which can ultimately lead to hypertension, and which would end up as an end-stage renal disease. So I just need to see there's one new message to new messages. Okay, so I think there's no question, because constantly people are showing that there's some chat going on. So okay, so what is the incidence? Incidence means what is the percentage which is happening in children. So we call it incidence of urinary tract infection. It varies markedly with the age and sex. We all know urinary tract infection is more common in girls. You can see in the third bullet that in childhood 10 times more common in girls than boys, and it is twice as common below 1 year of age. So if we see a child who is a male and is not circumcised and he is less than 1 year of age, there's 50% more chances to have a male child to have urinary tract infection. But circumcision is something which really helps in avoiding the urinary tract infection, and for that reason, after 1 year of age, this chance of urinary tract infection increases in girls, and the main reason for that is the urethra is smaller in size, and that in girls than boys. And we all know it is more concealed part, and it is more in girls. It is more open, and it is the urethra is very much close to the vagina and the anus. So contamination chances are high in girls. Around 2.5% of school-age girls have UTI, and 60 to 80% chance of recurrence. So if a child comes to you with urinary tract infection, and if it is first time, there is very much chance, which is around 60 to 80%, that this child can again have urinary tract infection. So for that reason, we need to keep an eye on a child who really develops urinary tract infection. You would not say it's just the burning of micturition. You need to have urine culture proven organism showing that this child is having urinary tract infection. Then you can need to evaluate for the recurrence. So what is the etiology? Etiology means what are the organisms which normally cause urinary tract infection in children. So it is the most, E. coli is the most commonest bacteria, and the reason is E. coli is an organism which normally colonize in our gut. So anal region and the urethral region are close by, especially in children less than 3 years. Children are the ones who use Pampers. So the stool can cause contamination of the urethral region, and it can cause urinary infection. And for that reason, E. coli is the most commonest cause, and it approximately accounts for 80% of urinary tract. So if somebody asks you, okay, what is the most commonest etiology or the organism causing urinary tract infection, your answer would be E. coli, because 80% is because of E. coli. There are other organisms which can cause urinary tract, like Klebsiella, Proteus, Enterobacter. It could be gram-positive bacterial pathogens like Staphylococcus saprophyticus. I know the names are very strange, but you need to remember, and we will be just going through again and again. And I'm sure this is third year now. You guys are coming into the clinical things more, so definitely you'll be able to understand. I understand when I was a third year or fourth year student, so I used to think, "Yeah, ये नाम कैसे याद होते हैं लोगों को?" but it would happen inshallah ta'ala. So E. coli is the commonest, Klebsiella proteus, Enterobacter can be the cause, Enterococcus can be the cause. The risk factor fungal urinary tract infection is very much less likely, but if there's a patient who is on immunosuppressive medication or he is immunocompromised secondary to congenital immunodeficiencies, or because of there's something, some foreign body is in the urethral canal or the urethra, means prolonged indwelling urinary catheters, these can be the risk factors for fungal UTI. So fungal UTI is not common in normal children, but yes, it can be a cause of urinary tract infection in the children who are immunocompromised secondary to long-term use of antibiotics, secondary to use of steroids, some secondary to use of immunosuppressant medications other than steroids, and having some foreign body within the urethral region like indwelling catheters or so. So, and viruses is the least common cause of UTI in children. So what I talked about in the first slide, that there's upper urinary tract and the lower urinary tract. So it is basically that it depends on that the kidney and ureters will be involved in case of upper urinary tract. So there is a demarcation. The infection above the bladder means kidney or ureters would be upper urinary tract infection, and if it is only the bladder or urethral region, then it would be lower urinary tract infection. It can be difficult on clinical grounds to distinguish between cystitis from pyelonephritis, particularly in young children. Reason being, they are not able to express their clinical presentation. They are not able to explain exactly what they are going through. But you can get the clues by that if a child is at increased risk of renal scarring, I talked, if there would be involvement of the kidneys, like if the parenchyma of the kidneys involved and the ureters are involved, and there is a chance that there would be fibrosis. And whenever there will be fibrosis secondary to the infection, it would cause scarring of the kidneys. And when there would be scarring, it will cause other complications like hypertension, because the kidneys would be shrunken. There could be end-stage renal disease, because in fibrotic tissue is the one which would not be the functional kidney. So it can ultimately lead to end-stage renal disease or chronic renal failure, which is earlier than end-stage renal disease. So if you assume that a child is having upper urinary tract infection, so you would definitely would have a presentation with fever, which would be which would be high-grade fever. I would like to explain in this slide that whenever a child comes to you, we need to decide either it is high-grade fever or it is low-grade fever. So a fever which is more than 100.4 degree Fahrenheit, okay? It would be called as 100.4 would be called as what? High grade fever. And if it is less than 100.4, it would be called as low grade fever. So in case of pyelonephritis, which is upper urinary tract infection, we will always have high grade fever. The child would be sick looking, would be ill appearance. If you would press the costovertebral angle tenderness, you would be like, if between the spine and the end of the rib area, there's a triangle, you call it costovertebral angle. And if you press it, the child could scream or would, try to take your hand away or whatever. So it can show that, yes, that is the region where child is not feeling comfortable. There is some tenderness. If there is some known immune deficiency, it means a child who is having nephrotic syndrome, for example, in another 2-3 lectures, I'm going to explain you what nephrotic syndrome is. But nephrotic syndrome is a condition which is an immunocompromised condition, or any condition when there is autoimmune problem. Usually we do give them steroids to, cool down their immunity. So in that case, immune deficiency would be something which is called as idiopathic immune deficiency, in which we are giving medicines to decrease their immune system. Similarly, anything which is causing the obstruction of the urinary tract, means if there is urethral structure, if there is urethral structure, if there is stone in the bladder, anything which is abnormal in their structure, means somebody who is having known urological abnormality, there is a chance of upper urinary tract infection. So this is a very simple chart. You can see on the left hand, it shows signs and symptoms, and here we can differentiate between the pyelonephritis and the cystitis. So if there's fever which is high grade, more than 39 degrees centigrade or more than 102, it is common in pyelonephritis, but it is in cystitis, it is very unusual because cystitis is usually not a systemic illness. It is the local bladder issue. It is the inflammation of the bladder we call cystitis. So in case of bladder inflammation, it is less likely to have high grade fever, but in case of pyelonephritis, fever would be high grade. Constitutional symptoms are if a child feels lethargic, if a child doesn't feel active, these are called constitutional symptoms. Not eating well, these are common in case of systemic illness, which is pyelonephritis, and it is very unusual in cystitis. If you go for CBC, complete blood counts, you can see there would be leukocytosis, WBC count would be high, which is will be frequent in case of upper urinary tract infection, while WBC count can be normal in case of cystitis. Similarly, elevated ESR. ESR is erythrocyte sedimentation rate. You know, this is called acute phase reactant. There are other, I would like to share that there are other acute phase reactants. In that we can look for CRP, which is C-reactive protein, and even platelets can behave as acute phase reactants. So in case of acute infection, you can see there is increased number of platelets in CBC. So yes, ESR is another acute phase reactant you can see would be raised in case of pyelonephritis, but it would be normal in case of cystitis, which is a local problem. There would be a history of dysuria, frequency and urgency. It is something very important. You know, dysuria means somebody telling you that whenever he's passing the urine, feeling discomfort, or there's burning micturition, or a child may go, a mother can say if now he is going very frequently to the washroom and used to go to pee very frequently. In that case, it could be just local inflammation. So in case of pyelonephritis, probably you are not going to have this. Probably not going to have. It is variable. Sometimes you can have it because in some conditions, cystitis, if not picked up at the time and not treated properly, it can ultimately lead to pyelonephritis because it could be retrograde ascent kar jayega infection. So yes, initially शायद ना मिले, लेकिन later on you can have dysuria and frequency in case of even pyelonephritis. DMSA is a scan, which is basically dimethyl salicylic acid. It's always difficult for me. You can look into the book and you can read it. Although DMSA, we call it very commonly, it is the abbreviation for that. It's a radionuclide scan. Just to remember it, just look at DMSA. It showed S is there, which is for the structural abnormality ko pick karne ke liye, means scarring. So whenever there will be scar, it would be a fibrotic tissue, and fibrotic tissue is something which is not actually working properly. So the nephrons would be affected, they would be working less. So the area of uptake of the radionuclide dye would be less in those areas. So in case of pyelonephritis, because kidneys are being affected, there is fibrosis in the kidneys, DMSA scan would show decreased uptake by the kidneys. While in cystitis, the kidneys would not be affected, so DMSA scan would be completely normal. Similarly, we talked about for the clinical presentation, flank pain or costovertebral angle tenderness. I told you earlier, it would be common in case of pyelonephritis, but we can't comment in case of infants, means children less than 1 year, probably because they do cry by looking at the doctor, or if somebody else is touching them except their parents, they do cry. So we would not be probably able to comment exactly if they are having costovertebral angle tenderness or not, but it would not be present in case of cystitis. So this is something we talked that what could be the causes. We said they could be the organism, it could be the uncircumcised male can have UTI, there can be immunocompromised state which can cause pyelonephritis. But there is another condition in which there is a lot of chances of repeated UTI, and we do call it, it's an anatomical problem, we call it vesico-ureteric reflex. So it comes in the pathogenesis, or even repeated UTIs can be a presentation of vesicular reflux, or repeated UTIs can cause vesicular. It can be vice versa. So you can see there are grade 1, 2, 3, 4, and 5. I want you all to look at the picture first. So if we look at the picture of grade 1, we see there is yellowish discoloration, not discoloration, there is yellow color in the bladder, and then this color is going up in the ureter till that black line which is horizontally being drawn over there. So this shows that actually vesicular reflux is something we try to diagnose via micturating cystourethrogram. I'm sure it's in the further slides. So micturating cystourethrogram is something in which you put a dye in the bladder and you take a picture. So you would see that dye would be radio opaque and it would be in the bladder, it would be shining. But when you ask the child to pass urine, so when bladder would contract, ideally it should be in one direction. The bladder should drain or should empty the urine through the urethra. And ideally it should not go back into the ureter, right? As this line and this yellow color is showing. So if a child is having vesico-ureteric reflux, means vesico means bladder, ureteric means ureter. So vesico-ureteric part, whenever the ureter enters in the bladder, it has got anatomically, Allah Ta'ala has made it as an, it would be as an oblique insertion of the bladder. So it causes a there is one direction valve. So ideally, urine would come from the ureter into the bladder, but it would not go back from bladder to the ureter. But if there would be deficit in that valve, there would be reflux, and this reflux can cause cystitis, causing cystitis, and cystitis can lead to pyelonephritis. So pyelonephritis, if a child is having repeated pyelonephritis, you should look for vesicular reflux. So there are different gradings. Grade 1 is the one which shows there would be only reflux till the lower 1/4 or 1/5 part of the ureter. This yellow color showing going back, it means the dye is going back till the lower 1/5. So this is grade 1. If it is grade 2, that during urination, that dye would go up in the bladder and it will go till pelvic ureteric junction, PUV wala part jo hai, wahan tak jayega, and it would show that this is grade 2. But you can see the ureter is of normal, beautifully, it is not dilated. It is as beautiful as in the grade 1. But in grade 3, you would see the urine would go back into the pyramids of the kidney, and it would cause some dilatation of the ureter. So you can see in grade 3, it's written over there, there will be dilated ureter and a blunting of the chelical fornices, which are the pyramids. So it would causing the destruction of the internal structure of the kidney. In grade 4, there will be kidney would be grossly dilated and ureter is also dilated, and you can see the dye is going within the chelical fornices and within the pyramids of the kidney. And in grade 5, it is completely bad structure showing. You can always say it's a tortoise ureter. You can say elephant trunk kind of ureter, which is tortuous, very knotty in knot-like structures and dilated. So these are the gradings. I would say, I'm sure in this lecture you would not be able to understand it completely, but you try to read it later as well from the book, so you would be able to understand. So what are the predisposing factors? Every child is not going to have urinary tract infections. So there are some predisposing factors which can cause urinary tract infections, like poor hygiene. If a child is not having a good hygienic practices, if mother is not properly, washing the child. If in case of girls, if mother's technique of washing the child is not right, means as we know that E. coli is a normal organism which is in the rectum, and if a mother washes a child with the hand, and the hand's movement is from back part to the front part, means from anal part to the urethral part, so that hand movement can also cause poor hygiene, because that fecal material can go into the urethral area, especially in case of females. It's a kind of an open structure, so in that there can be contamination of the bladder. It can cause cystitis and ultimately can lead to pyelonephritis. Constipation again is something in which it's a predisposing factor for UTI. So whenever you see a child with history of chronic constipation, there's very much chance that these children would get urinary tract infection. Pinworms are the worms which usually would stay in the rectal region. It can cause a lot of urticaria, a lot of itch, and pain in the anal region. So children do scratch that area, and it can ultimately cause the contamination of the urethral region. Also, it can cause urinary tract stones. We talked about, if whenever there will be abnormal structure, or even there is a foreign body. Stone would be like a foreign body for the kidney, ureter, and the bladder. So whenever there will be stones, there is very much chance of having repeated UTIs. Posterior urethral valve is another urological problem, in which there would be a tag, or I would say there would be a membranous structure which actually hinders in the flow of urine from bladder to the urethra, and won't let the urine out of the body. So it can cause stagnant urine, and it can cause repeated urinary tract infection. Similarly, if you look at the hydronephrosis, another is structure abnormality. When the structure within the kidney would be more dilated, it would cause more stagnance of urine, and it would cause more urinary tract infection. Similarly, abnormalities of the collecting system, I already told you, if there would be blockage in the ureters, if there would be blockage in the bladder, it would be there would be blockage of the urethra, there would be chances of urinary tract infection. And female gender is very common after the first year of age and less than 5 years old. So predisposing host factors. Age, we said, in boys, if they are younger than 1 year and they are not circumcised, there's more chances of infection, and girls less than 4 years and more than 1 year, there's more chance of urinary tract infection. Lack of circumcision, we know in circumcision the foreskin has been taken out, so that there would be no secretions would be pooled within the underskin of the foreskin, so chances would be less to have male children to have urinary tract infection. Similarly, female infants have 2 to 4-fold higher prevalence of UTI than male infants. There are two reasons. One is not the two reason, main reason is the structural difference, because in male urethra is more concealed and it is not open, while in females it is more exposed part, and that fecal material can very easily contaminate that area. It has been proven in multiple studies that there are genetic factors as well. So, in first degree relatives of children with UTI are likely to have more UTI than other individuals, and there's a chance that there are good bacteria within the bladder which are less, or it has been genetically mutated, so it doesn't help in avoiding the urinary tract infection. And we know that whenever there would be obstruction because of the urological issues, there would be increased risk of urinary tract infection, and the reason is stagnance of the urine. Otherwise, urine is a sterile fluid, but if it would be staying for a long time, it can cause bacterial growth. So in what investigations we said we need to differentiate between either the child is having cystitis only or having pyelonephritis. To rule out that, you need to look for the WBCs, and I told you even acute phase reactance platelets can be raised also. So CBC is going to, complete blood count is going to help us to differentiate either there is a WBC count is in normal range or more. Urine DR is going to tell us whether there are pus cells or not. Urine culture is something which is definitely going to confirm the disease by having cultural growth of any organism. So we know that urinary tract infections definition was when there is growth of a single organism and the power is 10 to the power 5 per ml of a single organism, then we will call it urinary infection, and which could be seen in urinary culture. In imaging, we want to look for ultrasound because we want to see what is the structure of the kidney, what is the structure of the ureter and the bladder, is there any structural abnormality. So ultrasound is going to help us. MCUG is the one which is micturating cystourethrogram. This is going to tell us either there is vesicoureteric reflux or not, which I told you in the slide when we were grading the vesicoureteric reflux. You are grade 1 till 5, and DMS is the one when a child comes to you with repeated UTIs. You want to look at the structural change which can be in the form of scarring. So DMSA would be something which is going to let us know either that repeated infection has caused scarring of the kidneys or not. And if a child is having repeated UTIs and the DMSA scan is bad, it shows poor uptake by the kidneys, so it means kidney functions would be affected. So we need to look at the renal function tests like by urea and creatinine, right? So what is the goal of treatment of UTI? And the goal should be that we know a child can come to you with the complaint of dysuria, it can come with the complaint of fever, right? So in that case, we need to treat it symptomatically. So if a child is having an infection in the form, we can see that CBC counts are high, in urine DR the pus cells are high. So we are supposed to treat the infection by giving antibiotics, and if there's fever and dysuria and frequency, we need to relieve those symptoms as well. But in fever, we can give antipyretics. In dysuria, you can give uh, uh, you can decrease the acidity of the urine by giving alkylating agents. So in that case, dysuria would be decreased, right? So prevention and the long-term treatment would be something that if a child has developed complications like hypertension, we need to treat the hypertension. If a child has developed renal scarring, we need to look at the renal function so that it's not going worse with time, right? So we need to keep them in follow-up. And impaired renal functions and growth. If there would be impaired renal functions, so we need to look at the growth as well, because we know chronic renal failure and end-stage renal disease can affect the child's growth, right? And we need to look at the prevention of recurrence. It can be by counseling, by looking at the urinary status of the child on regular basis. So usual indications for hospitalization. We are not going to admit each and every patient. So what are the indications? We are going to tell a family that you should admit the patient for IV antibiotics, or parenteral therapy. So if a child who's having UTI and is less than 2 months old, it is an indication for admission to hospital and parenteral therapy. Reason being, less than 2 months old would be immunocompromised. As a small child, there's a chances of urosepsis. So yes, in that you need to keep a close eye, and for that reason you want them to be in the hospital. Clinical urosepsis means you have seen a child, you seems like he is having urinary tract infection, and when you look at the child, seems very toxic looking, means it's very ill looking. If you look at the blood pressure, that's showing hypertension and capillary refill, in which you look for, like, you put the apna thumb, you put on the skin and you press it and you just take it, in just 2 seconds you take your thumb away. So if it fills again with the pink color, it means the capillary refill is good. If it is more than 3 seconds, you would say that there is hypotension and this child may develop urosepsis, you need to admit them. Similarly, a child is immunocompromised in the form of malnutrition, in the form of some congenital immunodeficiency, or a child who is on immunosuppressive medications. You need to admit those children, because the immunity is already on the lower side and this child is having infection. So these are the children who can have urosepsis. Vomiting or inability to tolerate. Definitely, if a child comes to you and is not able to tolerate orally, so why would you advise them oral medication? You would ask them to stay for 24, 48 hours, depending on the condition gets better, then you can discharge them, but you need to give them parenteral antibiotics and fluids even. So lack of adequate, if a child comes to you and you are sitting in Liaquat National Hospital and a child comes to you from I would say from interior Sindh or from Balochistan. So that would be very difficult for the family to come again and again to you. It would be difficult for them to come back, or it would be difficult for them to be in contact. So it would be an indication. If there's adequate outpatient follow-up, you ask them to get admitted. And failure to respond to the outpatient. In that case, in the last point, I would say you saw a patient and you saw that yes, that patient can be treated as an outpatient. You prescribe an oral antibiotic and you told them to follow you after a week or 3 days or 4 days, and when they come back, you see there is no response, or even the situation is getting worse. In that case, you would like to upgrade the treatment from oral to parenteral, and you can ask them to get admitted. So these are the usual indications. What are the treatment? These are the medications. Ideally, these are the common names like amoxicillin, co-amoxicillin, trimethoprim, nalidixic acid, nitrofurantoin, cefixime, ciprofloxacin. You can look at the dosages, but I think at the level of third year, you don't need to remember that as such. But important thing is, if somebody asks you what treatment would you like to give, so important thing is you would like to give, you would, I always tell my students that whenever you see a patient, if you assume that this is urinary tract infection and you see and you know that the 80% chances are of E. coli, so you would try to think about what would be the best antibiotic for E. coli. It could be amoxicillin, it could be cefixime, it could be ciprofloxacin. So you need to think about the bug, means which organism is the one which can cause this problem, and by keeping that organism in mind, you need to decide about the antibiotics. So that would be the best way of treatment, and definitely you will send the labs. And after 48 hours, you see there's no response, you would upgrade your antibiotic. If you see that culture is showing some other sensitivity of some other antibiotic, and you have given the other one, you would like to upgrade as per the sensitivity. So this is something which is tricky, but not that tricky. It is just that you need to think, you need to listen, you need to make a proper diagnosis, you need to make sure what could be the right, what could be the organism, and then this organism can be the one treated by this antibiotic. So it's not a difficult task. So what would be the clinical response? Somebody asked you what would be the clinical response of your antibiotic. So the clinical condition of the most patients improve within 24 to 48 hours if you have given the appropriate antibiotic. In children whose clinical condition other than persistent fever worsens or fails to improve as expected within 48 hours, so this is the time when you need to broaden up the antibiotic, and you need to look into the culture and sensitivity results so that you can decide about which antibiotic to give as per sensitivity. So what would be the prevent? हमने कहा if it's a poor hygiene, there would be chances to make it into good hygiene. You know the constipation is the cause or is a predisposing factor. You would avoid constipation. You know you would like to see what could be the cause, if either it is vesicoureteric reflux or any other abnormality. If you see that there is structural abnormality, in that case you need to give the prophylactic antibiotics, and usually prophylactic antibiotics are the antibiotics you give in the minimum dose. It is not like giving 8 hourly or 6 hourly or once a day. It is always a minimum amount of the dosage. In prophylaxis, we usually give trimethoprim and nitrofurantoin, and you can see in trimethoprim it's 3 mg per kg per day in single dose, or nitrofurantoin. Just forget about it. But you need to know that prophylaxis has to be given in children who have recurrent UTIs and who have abnormal structural abnormalities, right? The complications we've already talked about multiple times, that if a child is having repeated UTIs, hypertension can be the cause, can be the complication, because there would be, I would say, remember it in that way, if there would be repeated UTIs or upper UTI means pyelonephritis, there would be fibrosis. Fibrosis would cause renal scarring. When there will be renal scarring, the structure will shrunken down, it would cause hypertension. And when there would be renal scarring and hypertension, it would ultimately lead into chronic renal failure, and at the end it can go to end-stage renal disease. So in follow-ups, what follow-up you would like to see? Urine culture 1 week after stopping the antibiotics. So it means if a child comes to you and you make a diagnosis of UTI on the basis of culture, you treat it, and after treatment, like if you have, for example, you have given the antibiotic for 7 days or 10 days, you have completed the course, now you ask the family to repeat the culture after 1 week of stopping the antibiotic, and should be checked for recurrence every 1 to 2 months via urine culture for the first 1 year. So we need to see this child is having, it's possible that you are seeing a patient first time with UTI, but you need to keep a proper follow-up for 1 year. I would say not every 1 month or 2 months, you can make it quarterly. For 1 year means in 1 year, you can go for 4 urine cultures. And if you see the first time the child had urinary tract infection, and another 3 times when you looked into it for the 1 year and there's nothing, so you would stop, repeating those cultures. And prognosis in low urine tract is usually excellent because it is just a local problem, means it would be cystitis. And in pyelonephritis GARD, it guards the prognosis. If a child is having just one time pyelonephritis, there is less likely the chance of complications. But if a child is having repeated pyelonephritis, and that pyelonephritis was because of a zygote reflux or any posterior urethral valve or ureteric issues or hydronephrosis, then prognosis would not be as good as a single time pyelonephritis. So